What we do know is if you go through Adrenopause at the exact same time as menopause, you're going to have you're more likely to have particularly severe vasomotor symptoms and genitourinary syndromes of menopause.
So Kyle, it is so awesome to be sitting down here with you today. I first heard you on Andrew Huberman's podcast, one of my favorite podcasts, and I was just completely enthralled. It was a long interview, as all of his were, but just so in depth. I remember listening to it in the gym and thinking, oh my God, this guy is so knowledgeable. I'm going to have to find out who he is, where he is, and if I can, invite him to come on the show. And so I'm just so absolutely thrilled to have you here. Very warm welcome.
Thank you for having me. My pleasure.
Yeah, it's really great to have you here. So we were talking offline a little bit about different topics, and I think there's so many different rabbit holes really that we could go down. But a really good place to start is, let's start with women in their 40s, because I think this is the area of real disruption. And I think sometimes it kind of hits you across the face a little bit as a woman, right? Particularly if you've maybe had your children and you've had disruption like I did in my 30s, when you're having children and you're kind of prenatal, then your pregnancy, then your postpartum. You may have had things like me, like endometriosis, PCOS, you have all these things going on. And then all of a sudden it's a bit of a side swipe in your 40s when levels change again. And commonly, from my own experience that I see people in my clinic, women really struggle with metabolic issues, with anxiety, with poor sleep. Can you briefly explain for those listening what's going on during perimenopause?
Hormone health is a moving target. So throughout your lifespan, whether you're male or female, but particularly if you're female, you're not just finding the perfect formula and then continuing on. Because common problems are common, menopause or ovarian failure is extremely common. It's inevitable to happen in everyone, at least with current technology, if you hopefully live that long. So learning how to manage very common problems is what clinicians should do, because that's what helps people the most. And that's one of the reasons why I got into it as well. When you're thinking about the connection between metabolic health, body composition, energy, mood, libido, and hormones. Hormones are literally the signaling molecules that will send signals back and forth between different organ systems and within the same organ system. Endocrinology is in between organ systems. Autocrine and paracrine hormones are working on near or the same cells or organ system. And then intracrine is where you have, that's the intracellular endocrinology as well. So you have endocrine, autocrine, paracrine, and intracrine. And all those different signaling molecules will start the cascade. And there's an excellent article from the Mayo Clinic proceedings. Dr. Pataki, P-A-T-A-K-Y, wrote this. And you can see their flow chart that they published. And it starts with kind of in two different areas. You have hormonal changes, for example, menopause, and then you also have insulin resistance, metabolic syndrome starting. And then after that, it leads to sarcopenia, which is less lean body mass. And with less lean body mass, you burn fewer calories. So you have body fat deposition and muscle protein degradation. And this is what people colloquially know as metabolic damage that happens so often during and around the time of perimenopause.
That's really interesting. And the studies that I've seen particularly show that yes, women, and I think women sense this, they say, why have I got this weight? And it's not necessarily like they're piling on the pounds, but they see those body composition changes. And by that, I mean, they're not just seeing weight gain, which may only be, say, half a stone. It's that they feel and look different because muscle mass, as you say, is lowering. They feel all around softer, and then they're getting this belly fat that's going on. And that's something I don't know about you, I commonly see where they may have had other symptoms like anxiety, brain fog, hot flashes. They've gone and got some hormone therapy, but that isn't resolving these metabolic issues, which they still feel stuck with. And I think this is where resistance training becomes very, very important.
Absolutely. There is no better fat burner than lean, metabolically active muscle tissue. I hear a lot of women say that they feel like they're turning into a guy. A lot of times that is because they feel like they have body fat deposition in their abdomen subcutaneously, and they're depositing body fat more where a male might typically do that. But if you look at their hormonal profile, they actually have less androgens and relatively more estrogen dominant. And that really makes sense because that body fat in that area has a high level of aromatization.
Mm. And actually, from what I've seen as well is, I think estrogen or E1, the estrogen that's produced more predominantly after menopause, is aromatized in the fat cells, right? So actually, the way you enter menopause is key. So it's kind of like a lot of people are talking about this topic with women in their late 40s, early 50s who are coming with really strong symptoms. But actually, I feel as though if we can catch this early, women in their late 30s, early 40s, and get them really, really metabolically healthy, they're going to have a much easier time and a better life beyond 50. Would you agree?
I definitely agree. One excellent researcher, the late Dr. Labrie, he recently passed away. He was in his 80s, but he was one of the few scientists and clinicians. He was an MD PhD, and he studied endpoints for both hormone replacement and menopause, different interventions that you can do for essentially maintaining your health span. And he also studied cancer. And if you look at the ratio of estrogen, you have two main types of estrogen, central and peripheral. Peripheral is formed by aromatase. And he was one of the main ones that showed that all of your estrogen after menopause comes from the aromatization of adrenal androgens. So androgens that are produced in the adrenal gland, which is a small gland above the kidney. And then often those androgens like DHEA convert to estrogen to help backfill the estrogen. So of course, the better functioning your adrenal gland, so if you don't have adrenal fatigue, as that is colloquially known as, then you are going to have better estrogen production after menopause. You're also going to have better testosterone production after menopause. Even before menopause, you have about half and half of your testosterone, depending on the female, that's produced by your ovary in the theca gland and produced in your adrenal by the zona reticulosa.
So are you saying there that if you're less stressed, you're going to be able to produce more DHEA, which then allows some of that to be aromatized and some to still be available? Because DHEA itself is important, right? In terms of it's an anabolic hormone, it counters the effects of high cortisol. Whereas if you're not producing as much and you're aromatizing, then you're going to be low. Is that what you mean by that?
That can be the case, but not necessarily. If you're overproducing stress hormone like cortisol, then theoretically your adrenal factory can be so busy that it might produce less DHEA. However, one of the really interesting feedback mechanisms is that ACTH, which is adrenocorticotropic stimulating hormone, that hormone ACTH stimulates both cortisol and DHEA. So often if you produce cortisol better, you produce DHEA better as well. So that shows that things like cortisol burnout can also lead to DHEA burnout. If you look at the reference ranges of DHEA, it's kind of similar to andropause. If you're not familiar with andropause, basically it's what people call male menopause, decreasing testosterone. But both males and females have adrenopause, which is where your adrenals tire out. Some people go through adrenopause at age 30, and some people go through adrenopause at age 90. It is highly, highly variable. But what we do know is if you go through adrenopause at the exact same time as menopause, you're going to have you're more likely to have particularly severe vasomotor symptoms and genitourinary syndromes of menopause.
Yeah, that's interesting. So when you're talking now with adrenopause, you're talking about something that's biologically going to happen at some point anyway, as opposed to burnout, where now actually we can see like metabolized cortisol, free cortisol going down, and the body sort of almost starts to protect itself. So adrenopause is actually an event that will happen to everyone. Is that what you're saying, at some point in their life?
Given enough time, some individuals are extremely resistant. They have very strong adrenal steroid production. Some of these individuals have a mutation. It's called NCCAH, non-classical congenital adrenal hyperplasia, to where their adrenal glands just work great. If you have two genes for that and you're female, then it could possibly even, have a result of pseudohermaphroditism. But if you have one gene, then it's just enough to where you're particularly resilient against adrenopause. And often you have excellent estrogen and androgen levels, even into very late ages. There's been a lot of studies done with both DHEA, testosterone, and estrogen. And it looks like if you replace DHEA, the more normal your endogenous production over age, the less it helps, which makes sense. But if you're very, very low, then it tends to help more. And there's, it's interesting to look at this DHEA hormone because in different countries, I believe in the UK, I'm not board certified or licensed in the UK or anything, but I believe for a while it was brand name only. I forget the name of the brand name DHEA. In the United States, it is over the counter. You can just get it on Amazon because it's considered safe enough. In Canada, I believe it is prescribed only. And also in Canada, there's a lot of different medications that is essentially just DHEA combined with a different hormonal modifier. So depending on where you live, DHEA might be seen as a medication or a supplement.
So here it seems to be, it's one of those things where you can prescribe it as, for example, a nutritional therapist or functional nutrition practitioner. I can access that through practitioner accounts. But an individual wouldn't be able to just go, it's Biomatrix, I believe is the one that we have here. An individual wouldn't be able to go and order that themselves, except under the guidance of a practitioner, but it wouldn't need to be a medical doctor. But then my concern is with DHEA as well, is unless you know which pathways it's going down, it can be quite pro-androgenic, right? And cause other problems for individuals. So I'm sort of quite surprised that you could go and get it over the counter.
Yeah, and it can also be estrogenic. I've seen men develop gynecomastia, which is obviously not just due to estrogen signaling, but I've seen men develop gynecomastia just from a DHEA supplement.
Interesting. So with women, when we look at them, obviously we know that managing stress, managing their metabolism is key. How easy do you think it is, or should women, I guess, and it's always a bit of a controversial question, isn't it? Do you think it's possible? I mean, it must be possible because we had women do this multiple times previously. But in today's current environment, we're seeing such significant hormonal disruption. You probably don't see them in your practice because people who have problems will be the ones coming to see you. But how common do you think it is? And how easy is it to make that transition through menopause without symptoms, without needing anything?
PCOS, all the different axes of PCOS. Of course, there's a lot of different axes, which maybe we get into as well. But I would say the prevalence of that is around 30% in the population of most developed countries. Most people that have it don't know, and most people tend to have a fairly mild case. Infertility is extremely common, and subfertility is even more common. I would say at least 50% of couples, whether it's male factor, female factor, or third factor where it's combined, at least 50% experience some degree of subfertility in developed countries for varying reasons. A lot of it is things like metabolic syndrome and sleep apnea. And then even rare diagnoses like hypothalamic amenorrhea or premature ovarian insufficiency, those are becoming much more common as well. Adrenal fatigue is another one, or just adrenal relative subclinical hypoplasia. And then I certainly count thyroid hormone pathology among that. That is, of course, becoming more and more common.
Super common. And what about like the transition through to menopause? And if you've got a woman who is managing her stress, she's physically very active, she's been looking after her metabolic health, maybe she didn't have any of these problems previously, she's had a regular cycle. Are there many women who can then make that transition without having, vasomotor complications and all the other things that we hear and see?
In general, the better you are able to optimize your estrogens and androgens without the ovary, the better your transition to menopause. However, even if you have an optimal profile, it does not necessarily mean you will be symptom-free. And even if you are mostly symptom-free, it does not mean that you should not consider optimizing your hormones naturally or even somewhat naturally. So again, to use DHEA as an example, because it's a supplement in the States or because it's relatively easy to get, some people consider that hormone replacement therapy and some people do not. Some people consider synthetic estrogens and progestins like contraceptive pills. Some people consider that hormone replacement therapy, as I do, and some people do not. So thinking about doing something with your hormones, I would say 100% of females should do, and they should do it earlier rather than later. So if you're considering it, the time to get lab work up and look at your baseline levels and use the accurate, precise biomarker would be yesterday rather than today. Another thing to think about with estrogen signaling is that there's 2 different estrogen receptors and various things can affect them. There's also many estrogen-related receptors. For example, there's estrogen-related receptor alpha, and that one cholesterol binds to. So cholesterol is actually a hormone in and of itself. It's a ligand where it binds to that receptor. And there's also one people might be more familiar with, estrogen-related receptor gamma, and that's what BPA or bisphenol A binds to.
Okay. I want to get into that actually to do with sort of environmental estrogen disruptors and mimickers in just a moment. But when we're looking then, sticking with what you were saying there in terms of testing, so how often should women be testing their hormones? Is it like an annual workup or more often than that? And at what point should they then be thinking about, because there's this theory of this sort of critical window, particularly with things like brain health. What do you advise women? At what stage should they be checking their hormones in an ideal world? And when should they then be looking at potentially introducing hormone therapy?
A good rule of thumb as a baseline, of course, you can always do more if you want to optimize things. But to get ahead of the 8 ball and use true preventive medicine, then once a year up to about the age of 40, and ideally twice a year over the age of 40. Of course, you would want to follow how you're doing subjectively. So if you're starting to have menstrual abnormalities, like if they're spacing out, which we call oligomenorrhea, then you want to be a little bit more proactive with that, especially if you haven't had a menses in, say, 6 months. You would certainly want to get a workup, because if you do need to start or tweak something, doing it as early as possible is going to be by far better efficacy.
Okay. And one of the things I see women in the early stages, they seem to struggle with the most is, rather than the cycle lengthening, it seems to be shortening. And actually they're getting heavier bleeds, and they seem to effectively they're producing less progesterone. In that scenario, is that a place where actually they should be thinking about optimizing and maybe taking hormones at that point, or using maybe natural things that can support? Because I know, in many instances, a lot of doctors will say actually we can, or functional medicine doctors will talk about using things like maca and things like that to try and sort of optimize levels until there's further disruption. I'm just curious on your view.
Yes, depending on the patient, each one of those things could work. For patients with really severe symptoms, and that have congruent hormonal profiles, the chance that you can optimize with something, for example, just maca, is certainly a lot less likely than for someone with mild symptoms that has mildly suboptimal hormone profiles. For that individual, something like maca might be a lot more reasonable. When you look at hormone productions, progestins, for example, progesterone, pregnenolone, 5-alpha and 3-alpha progesterone, those drop much more quickly than estrogens. So usually estrogen is the last hormone to drop during the perimenopausal time. So a lot of women do start progesterone. Of course, there's risks and benefits to starting any medication or hormone, but often that is what we see. In general, if your FSH is not suppressed, and the units might be slightly different, in the UK. But if your FSH is still below around 35 or 40, you should certainly attempt not to start any estrogen until it climbs higher and higher. There are exceptions, of course, but that's another good rule of thumb.
Okay, that's interesting. At what level would you then start to look with estrogen therapy?
As far as like
With looking at
hormone replacement therapy with estrogen,
yeah,
if you are no longer having menstrual periods, that's another good one to see, because even if let's say your FSH is 70, but you still think you're having very frequent menses, perhaps that's an like endometrial hyperplasia or even an endometrial carcinoma, worst case scenario. So you want to make sure that you're no longer having endometrial bleeds or menses. And then looking at an FSH above 50 would be quite safe. When those criteria are met, then especially if you're at a younger age, you certainly want to consider starting estrogen sooner rather than later, because once you are truly in that menopausal time and your estrogen is low, and specifically looking at estradiol most of the time, and your FSH is high, the longer you wait, the less benefit it will bring.
okay. Yeah, I'd read that. That's interesting. And so what about with progesterone? Because obviously, like, as you say, that sort of drops quicker than estrogen, but it's estrogen that brings the more obvious symptoms to women, isn't it? When they say, oh, I've got terrible hot flashes, I'm waking up in the middle of the night, or really bad brain fog, I just can't concentrate, and things like this. Whereas progesterone is sort of sneaking out the back door, you're getting more anxious, you're not sleeping quite as well, these symptoms going on. What are your thoughts about women just taking progesterone?
Some women are great candidates for progesterone monotherapy without any estrogens. It just kind of depends on the individual. Some people have bad reactions to progesterone as well. It's not very common. Oral progesterone is not very bioavailable, so not a lot of it is absorbed in the gut. And then also, in order to cross the blood-brain barrier, it has to be reduced. So 5-alpha reduced and or 3-alpha reduced. So depending on the individual, they might do that better or worse. Supplements like creatine can help upregulate the amount of 5-alpha reductase to help that progesterone cross the blood-brain barrier. It's known as DHP or THP, kind of like testosterone converts to DHT. But depending on the individual, many do very, very well on just progesterone.
That's interesting about the creatine. And is that a usual, like, just standard dose of kind of 5 grams daily?
For most people, 5 grams daily is a good dose. Some individuals that are non-responders or that just exercise a ton, they use more creatine. I think of it as the backup fuel tank for the mitochondria, which is important for maintaining ovarian reserve as well. When I think about the mitochondria, the creatine is the extra fuel tank to basically hold that phosphate group for ATP. And then CoQ10, ubiquinol, is the active form of CoQ10. That's kind of like the enzyme or the fuel converter that converts that NAD into ATP. You need coenzyme Q10 to do that. And then NMN, NAD+, even NR, those are even niacin. Niacin actually cures NAD depletion myalgia as well, which is just vitamin B3. But those different NAD and ATP precursors, that's the actual fuel that helps go in. And then L-carnitine is the fuel pump. So that helps facilitate the transfer of fatty acids and fuel in general into the mitochondria. So all of those things are important to ensure that you have them optimized in order to maintain the quality of the ova or ovarian function and fertility into older ages. If you look at mice treated with these various interventions, particularly NAD+ precursors, they can even have reversal of mouse menopause, if you will, and regain fertility.
That's super interesting because so I recently have been taking NAD+ precursors after interviewing a biochemist here in the UK. Actually has a very good supplement range alongside creatine, because I train a lot. And I've really noticed, I hadn't realized that research around ovarian function, but noticeable differences in energy, noticeable. And also interestingly in deep sleep, and also just not actually needing quite so much sleep. I almost have to be careful that I'm not undersleeping. It's quite interesting. Yeah.
Yeah. That's one of the potential downsides or upsides, is that it can improve your sleep. It helps the mitochondria everywhere, not just in the ovaries, of course. But when you think about that, you're essentially optimizing your ATP. And you do have to be a little bit careful with doses there, even though NAD plus precursors are very, very safe. There is theoretical risk behind them, because they can provide so much energy that if you do have something like a cancer, then theoretically they can provide that energy as well. It is a relatively small risk, but there's a benefit and a detriment to everything. When you're thinking about your rate limiting step, let's say that there's an individual that is deficient in coenzyme Q10, and perhaps they need CoQ10 in order to unlock that NAD plus, or to actually utilize that creatine. Or maybe they have trouble pushing their nutrients into the mitochondria. Insulin resistance can contribute to this as well, because a lot of your fatty acid chains like triglycerides or glucose are outside the cell instead of inside the cell. So those four kind of work together synergistically. And for individuals trying to maintain ovarian function, that is one vector. We can also talk about sirtuins and hormesis, or things like mTOR and rapamycin, and that kind of like mTOR AKT PI3K pathway.
Yeah, I'd like to talk about that. When you talk in just a second, when you talk about like sirtuins, I'm just curious in terms of your thoughts around resveratrol, because that seems pretty controversial in terms of its actual bioavailability and absorption. Where do you sort of come out on that?
Yeah, and some people take it with fat, which might potentially increase its bioavailability. And some companies have formulated it to where perhaps its bioavailability is better. And it is one plant polyphenol. I don't think there's anything magical about it. I forget, it's either SIRT1 or SIRT3. I think SIRT1, that it pretty profoundly changes the activity of, increases the activity of SIRT1, I believe. But it's just one plant polyphenol. It's kind of like, I think of it as maybe similar to boron or zinc for hormone health. If you happen to have a really, really hyperactive or really, really hypoactive SIRT1, then perhaps it's helpful for you. But it's just one of the many plant polyphenols that can be helpful from a hormetic standpoint and from an antioxidant standpoint. So just like giving everyone zinc is not going to fix all hormone pathologies, if you happen to give zinc to someone who's deficient in zinc, even if they're just deficient intracellularly, like it's more common in older ages to be deficient intracellularly for zinc, but not in the blood. Resveratrol similarly is not, like a magical antioxidant sirtuin activator.
So do you look at like sirtuin activators then more from like incorporating them into your diet? So kind of adding cacao into smoothies, drinking maybe matcha green tea, I mean, from an antioxidant perspective, certainly like chaga, I think, 1 teaspoon of chaga is giving you the antioxidants of like 600 blueberries. So there's as you say, there's the hormetic influence, and then there's the antioxidant, right? And they're not always the same in each. Yeah, I'm just curious what you advise with patients there.
Some patients have such a wonderful diet with many different plant-based antioxidants and hormetic activators that they just simply, it's not going to be clinically significant to take a supplement that helps. Some individuals, and I'm trying not to pick on anyone, but just as an example, let's say there's someone who's on a carnivore diet, they're not taking in any plant molecules, and they do not intermittent fast. Their mTOR is always active, and they're in a very anabolic state. Then perhaps they would benefit more from something like chagas or shilajit or resveratrol or quercetin, or a lot of these different, some people call them adaptogens, some people call them SIRT activators. That's just one example of a patient that might benefit more from a supplement regimen like that.
If they're not, yeah, as you say, if they're not really getting any of it in their diet.
Mhm.
And I think this is the thing, isn't it, is with women in particular, not including plant compounds, to me just feels very deleterious because of the profound effects on gut health and gut motility, and actually detoxifying excess estrogen. It's always sort of concerning to me. And I've seen some funny things with the ketogenic diet where women have prematurely gone into menopause, it seems, and then actually even post 12 months, when they come off that diet and they go on a more plant-based diet with sufficient protein and healthy fats, their menstrual cycle resumes.
Yes, that sums up what the most powerful intervention for almost all females is. I am a very strong believer in food is medicine, and it is the main medicine. And as you mentioned, if they're not getting those things in the food, then all the different band-aids of supplements and medications are only going to bring a fraction of the benefit that those dietary changes can.
Yeah. I think what women are really concerned about at the moment is there is so much on social media around controlling blood glucose that it's almost become an obsession, that they're very concerned at any point, what happens. And I see this with women who, I mean, I have it here on my desk, like I play with the Lumen device, for example, and I do find it really useful to see, am I burning fat? Am I burning carbs? But from my perspective, and I'm always quite competitive with things. I understand that burning fats and carbs is a good thing because that's true metabolic flexibility. I think people get hung up on, I need to be in fat burning all the time. And actually, it's those individuals that I find have a harder time of reaching a 1 or a 2. Whether that's because these devices are not advanced enough and they're misinterpreting ketos, whether those, which I've seen some reports around, or whether actually these individuals are kind of almost in a state of high stress all of the time, that their body's now producing it. I'm curious to your thoughts around that, and also the level of hormetic stress that women in their menstruating years should be placing, because fasting, again, is a form of stress. I guess, first of all, when we're looking at blood glucose, people take their HbA1c levels, and we want to get it to an optimal level. It's something, for example, I am monitoring and always want to optimize because I'm someone who has PCOS. So it's a big marker for me, and I probably have a harder time controlling blood glucose. But obviously what we're seeing on the internet is constant graphs put out and books at the moment of, look what happens if you have this, and very natural foods that people are completely steering away. It's like, right, don't have oat milk, only have almond milk now, because you're going to get this huge spike. How much do you think we really need to be worrying about natural foods providing a momentary spike if actually we're doing all of the other things like sleeping well, exercising well, for example?
It somewhat depends on how high the blood glucose spike is. That's another reason why CGMs are becoming more popular, and soon there will be CGMs that measure ketones and lactic as well, which will be particularly interesting from a metabolic standpoint. As far as how important, your insulin resistance and blood glucose markers, for example, a glucose tolerance test, or even just what a CGM puts out, it is certainly important, but it is not the only vector for holistic health. It's not even only the vector for metabolic health. It is good that that has been added as an addition. So many people are a little bit obsessive about it and reductionist. And by reductionist, I mean that is all they care about. Some groups, all they care about is calories in, calories out. And of course, being obsessed with the physics of that is not going to lead to helpful clinical endpoints for everyone. It's very helpful, and you have to address that. And you also have to address the metabolic flexibility. But for optimal health, just like if you're trying to tune your car, you're not just looking at how much gasoline you're putting in and burning, and if you're overflowing the fuel tank or not. You're not just looking at the efficiency of how the motor runs. You need to look at the aerodynamics, and you need to look at how the wheels are spinning and how much friction you have on the ground. So when a clinician or a scientist tries to reduce everything to tracking calories and then tracking the health of an individual's blood glucose and insulin, for example, those are absolute musts, just like it is an absolute must to track the fuel you put into and burn in your car, and also how efficient the engine is running. But there are so many other things to take into account.
Mm. And what would those things be? Because when you look at it, for example, you may find that, let's say, I know from interviewing like the founder of one of the blood glucose companies, or the CGM companies, all the data they've collected, right? We had a chat laughing about it. Bananas make your blood sugar go bananas. Okay. But then the most common food for making your blood glucose spike was sushi. So it's kind of almost a no-brainer. Well, if white rice is going to cause a spike, which gets metabolized into glucose, very quickly, it doesn't really seem lots of vitamins in white rice. It's sort of a no-brainer of this should be an occasional food. But a banana is something different because, and it's interesting because actually looking at my own measurements, if I take bananas from the grocery store while they're green, chop them, peel them, chop them up, put them in the freezer, they're great because they contain a lot more resistant starch, which is good for your gut, and then put them into a smoothie. And I say use half a banana, very, very minimal spike, if any, in blood glucose. And I feel like I'm getting the benefits of that banana. Whereas take a ripe banana off the stand and eat it, it's going to be a spike. But then, from what you're saying there, you make a very good point. There's loads of other things that you're getting from that banana, right? There are vitamins and minerals and things that are having an impact, and fiber on your body. What other things should we be looking at then, do you think, in making these decisions?
One of the main ones is just your lifestyle pillars. So your exercise, your sleep, your level of stress. You want enough stress, especially in the morning, and not too much stress in the evening in general. And yes, most people have too much stress, but you don't want to have too relaxing of a morning. You want to get into that cycle, just like you get into the melatonin cycle. You want to get into your stress and cortisol cycle. So you want to address your pillars of lifestyle, but the main other objective marker that you're looking at is your hormone health. You want to have good thyroid hormone health. You want to have good growth hormone and IGF-1 health, and good androgens, estrogens, and progestogens. And then from that, you can look at things like how your androgens profoundly directly impact your VO2 max, or your ability to carry oxygen to end tissues. VO2 max is probably the main health span marker. So if you can look at all the other markers and compare them to VO2 max, and if you take an 80-year-old with very, very good VO2 max, they're probably much healthier across the board than someone with a far suboptimal VO2 max. And that's directly impacted by your androgens and many other things as well, including your mitochondria. So that's one of the main angles that people are missing. And I think more people are talking about it, but there just needs to be a consolidation, if you will, between the traditional academic medicine and the functional medicine, for lack of a better term. There's this cultural shift to where people do care about their hormones, but usually the individuals that they seek advice for their hormones are not the most reputable and accomplished scientists. They're usually not MDs and DOs and PhDs. They're often knowledgeable, but often they're just not those individuals with terminal degrees who are publishing clinical literature on the science. So there's a little bit of a discongruence between the scientific community and the cultural community. And that is slowly coming together. And those two groups are approaching each other and collaborating with each other as well, which is very reassuring.
It's really interesting what you're saying. I want to dig a bit deeper there with things like VO2 max, because a very interesting concept that I've been sort of looking at, and I first heard from Peter Attier, is this concept of backcasting and looking at what's going to be effectively your last decade, and then tracking back from there. And most people fall very much behind, is what he's found. So for example, if you really think that your last decade, you want it to be somewhere between 90 and 100, actually most people in their 40s and 50s are falling well below on VO2 max, and interestingly well below on grip strength, right, which is a big marker of aging. In terms of VO2 max then, I'm curious, how are people's androgens affecting their VO2 max, and can we train our way out of anything that may be adversely impacting it?
Testosterone, specifically the binding of any androgen to the androgen receptor. If you increase the density of androgen receptors in the cytoplasm of a muscle cell, it will, think of it as it's grabbing onto that oxygen and helping to hold on to it. In addition, and the mechanism behind this second vector is not well understood, but it also increases EPO, which is known as erythropoietin. And all androgens do this, not just testosterone. But this erythropoietin will cause increased production of hemoglobin and red blood cells. And that extra hemoglobin in the blood will also carry more oxygen. So you're carrying more oxygen and you're absorbing more oxygen as well.
Okay. And there's also a kind of genetic component from what I've seen from DNA reports as well, in terms of your VO2 max potential, right?
Yeah, there's absolutely a genetic component.
Yeah.
So even if you have not ideal genetics for a high VO2 max, it still is just as beneficial. So you're really competing against yourself when it comes to VO2 max.
Yeah, and improving it. And that's through a combination of kind of zone 2 training and then also very high intensity training.
Yes, especially very high intensity training. Runners and cyclists and swimmers might be familiar with VO2 max workouts, which are some of the hardest to do. And usually those are very high intensity. And then zone 2 is essentially training for your mitochondria. And also it helps your sleep profoundly. It helps your REM sleep specifically.
Oh, that's interesting. I hadn't realized that zone 2 was helping REM sleep. That is interesting. And around how much is it? Wait, do you want to just briefly describe what zone 2 is? Because people might be wondering what that is.
There's 6 main zones of cardiovascular exercise. Zone 2 is one of the very easy ones for most people. It's a bit over 100 as far as your pulse, your beats per minute. So most of the time you can talk through it. A stroll that's a little bit difficult where you're sweating a bit, but you can still talk is a good way to do zone 2. And then a lot of fitness trackers will also just tell you if you're in zone 2. So that can make it a lot easier.
So this is where I think it's a really difficult boundary, isn't it? Because walking, for example, with your dogs and you're listening to a podcast, you're probably not quite getting into zone 2. You're kind of on the very upper limit of zone 1 right here, which isn't enough. Then you've got zone 2, where if you start jogging, for many people, they'll be like, my heart rate just goes quickly too high. Something I've been playing with that I really, really enjoy, and I find it as relaxing. I mean, I guess this is why people runners say it's like meditation to them, is purely nasal breathing running. And I found that with that, you can come back. It's a very parasympathetic state where you're in and out through the nose, and you can just go on and on and on. And that seems to me a good way of measuring whether you've skipped out of zone 2 and you've just gone a little bit too high, because it becomes quite difficult to maintain nasal breathing once you move out of zone 2, is my understanding. Is that correct?
That's a good rule of thumb. Some people are particularly good at breathing through their nose, which is a good thing. That's a pretty good rule of thumb, though. A brisk walk or a power walk for some people would be zone 2. It really just depends on the person. So the more fit you are, the more the faster you'll have to walk if you're using walking as your zone 2 cardio.
So then you kind of need to move into a cycle, or swim, or a jog, or something like that.
Possibly, or just almost everyone can get into zone 2 with a very brisk power walk.
So from a heart rate perspective, this is sort of, for most people in their 40s, is going to be around somewhere between 120, 130 or 135, right?
Yes.
Yeah, somewhere in that zone. And this is, my understanding is that for optimizing for that, you need to do around 2 hours a week. Yes.
A good rule of thumb is at least 3 to 5 times a week for 30 minutes each. Okay. Like anything else, the law of diminishing returns applies. So if you do 2 hours a week for 50 weeks, that is going to be far better than 4 hours a week for just 25 weeks. So consistency matters more than, I guess, the cumulative number over a year.
And going over that and doing, say, 5 hours a week doesn't necessarily confirm majorly big benefits beyond doing the 2 hours.
I'm not sure how much the benefit is, but I know that if you do, for example, 4 hours a week rather than 2, it is not double the benefit.
Yeah.
Maybe 20% more, maybe 60% more, but certainly not 100% more.
But it sounds like it's a good way actually of getting your dogs walked, or certainly my ones, a lot quicker than just strolling along, because you're going to do it in half the time and benefit your VO2 max and your longevity. And that is also going to help to optimize hormonal health, is what you're saying.
Yes, it is quite nice. It will also help raise SHBG. Many people struggle with too low of an SHBG, so they can't hold on to their androgens or estrogens. So there's a lot of fringe benefits of exercise. That's why I put it number 2 right after diet and the lifestyle pillars. Those two are, they're all important, but those two are the most important.
So talk us through those pillars that you use. What are those?
Diet and exercise are the first 2. And then the last 4, I used alliteration. They all start with an S, but stress is one of them. And that includes social stress and collective health, the health of the family and close friends in your household. And then you have sunlight, which is really just being outdoors. It includes cold exposure, heat exposure. And then you have spirit as well. So this is just where you are on Maslow's hierarchy of needs. Fortunately, in developed countries, most people are concentrating on the self-actualization, the very top of the pyramid, rather than the bottom of the pyramid, which is their more their physical needs at the bottom of the pyramid. So that's very reassuring. But diet and exercise are really the main 2. Sleep is the 4th S, if I didn't mention it yet.
Yeah, so sleep is
important.
important.
Deep sleep is important, looking at your heart rate variability, looking at your REM sleep as well. And these 6 interventions are more powerful than any medication or supplement.
Yeah, really, really powerful. I think as much as everyone wants to take, the supplement industry has become almost like a prescribing platform, I think, just no different almost than medication. I think these are all great, but if you haven't got those pillars in place, there's almost, yes, you can take supplements, but I agree with you. I concentrate on those first. We talked a little bit offline, and I really want to dive into this because we talked about VO2 max there, but also the benefits of athletic performance and the interaction with hormones and cognitive health, because I think this is really, really important. What do we need to be thinking about in terms of exercise? The research I've been looking at this week is just super interesting around weightlifting and how that's really, really benefiting cognitive health. But I'd love for you to share more, because I know this is an area you're very knowledgeable in.
There's a lot of theorized mechanisms behind why certain types of exercise help decrease the risk of neurodegenerative disease, so decreasing the risk of dementia, and also improving cognitive performance. In the long run, if you are routinely resistance training, then perhaps that helps increase oxygen delivery to the brain. But it's also possible that that just helps the signaling of hormone molecules, the prevention of sarcopenia, which is the decreased amount of lean body mass over time. And that is very closely correlated and possibly causatory with the decline of the health of your brain. So your brain and your other lean body mass and your muscles are very closely related. Also, the amount of lean body mass you have and the amount of bone mass you have, which is another type of lean body mass. So muscle mass versus bone mass. So sarcopenia and osteopenia or osteoporosis are very closely related as well. If you look at individuals that have the highest risk for dementia, often they did not do any sort of hormone optimization or hormone replacement therapy after menopause. And then 2, they're usually obese during the middle ages, and then they lose weight as they age, and then they are at their lowest weight in their older ages. If you look at individuals that are the same weight the entire time, whether it's low or high, they're much lower risk of dementia, and resistance training can help maintain that good, healthy body mass that helps retain the good, healthy brain mass.
This is interesting though, because what you're saying there then is if you have somebody who is obese, but they continue to be obese, their brain is better protected than if they lose weight.
Absolutely. And part of that reason is the extra adiposity, the extra body fat helps produce more peripheral estrogen. Those individuals have more estrogen around, which can help with serotonin tone and also myelinization, so that it helps maintain the fatty sheath around the nerves. And it might help prevent some of that cerebral atrophy or the shrinking of the brain that is expected with age. Many people have seen a CAT scan or an MRI of, an octogenarian, and almost always there is some degree of cerebral atrophy, more so in someone who's a heavy nicotine user, or that has certain, more so if you have osteoporosis as well. But the extra estrogen from maintaining that high body mass and high body fat percentage. And part of that reason is if you, I'm not good at conversion of pounds to stone, but if you're a very high BMI or you weigh a very high amount, then it is likely you're very strong legs and a relatively strong core and a very strong back as well. It takes a lot of strength. It's almost like your resistance training every day.
Just carrying yourself around, right?
And that helps you be a much lower risk of dementia. If you look at the average amount of lean body mass that you lose as you lose weight, for every pound that's lost, over a third of that is lean body mass. So if someone loses 100 pounds, then maybe 35 or even 40 pounds of that will be good, healthy, lean body mass that was metabolically active.
Unless you can intelligently do this right by losing, like strength training, eating high protein, and trying to minimize any kind of lean body mass reduction.
Correct.
Yeah. But then I suppose being obese, you're predisposing yourself to other diseases like cancer, potentially.
That's true. Very true.
Yeah.
For example, breast cancer.
Yeah, which is difficult. So it's a balance. And so what about, for example, do you think that people who are naturally very lean, for example, and by that I don't mean necessarily they have a high lean body mass but are quite petite, and then they just continue along that line, are they likely to experience, are they more at risk of things like dementia?
Not that I know of. They are certainly more at risk of osteopenia and osteoporosis, which is low bone mass.
Okay, low bone mass more, which actually, interestingly, I think you can do DEXA scans annually, right, to have a look at this. With this concept of hormesis and stressing the body, this is another kind of quite controversial area around how much do we, as women in our cycling years and then in the lead up to menopause, how much do we fast? How often do we, like the fasting, the length of that period? Because I know, some people are very pro fasting, but it can disrupt female hormone health, and also exercise. There's growing evidence around restricting really intense activity in that late luteal phase. I'm curious about your thoughts around both those areas.
Part of the controversy regarding fasting is that, one, it is not done to improve body composition or lose body fat. It's just one tool that can help develop good eating habits. That way you're not dieting, you have a diet or a habit that will last a lifetime of good eating habits, kind of developing intuitive eating, if you will. Fasting can certainly help that. And it can also help control the hormones like leptin and adiponectin and ghrelin that crosstalk between fat cells, adipose, and the brain. When it comes to how much fasting an individual should do, it's down the list quite a bit after other lifestyle interventions. It can be relatively easy to do for some people, but if it's really difficult to do for an individual, it's a weak enough intervention to where it might not be worth it. So if you're struggling and you're suffering through fasting, and it's not just the first few days where you're getting used to it, it's a month or two in where most people do acclimate to it and it's still difficult, then it might not be worth it. And then the other thing to think about is there a particular reason why this individual is a great candidate for fasting? For example, a strong family history of brain cancer, as just one example. So that would be for more of a health reason. But intermittent fasting is not going to like make up for, let's say, poor sleep, dysregulated stress and a mental state, and just poor collective health within the household as well. On a scale of 1 to 10, I'd give fasting, for like compared to those things, 10% of the benefit.
I think it has been like overestimated in many respects, or sort of inflated, right, by different books that have come out and social media. Because I recently was talking to Dr. Joseph Anton, who's the CEO of Prolon, and we were discussing at length how, you know, it for most people in a lean individual, they may after 24 hours begin to stimulate full cellular autophagy, but it's unlikely. Most people are going to take about 48 hours. And the reason that they, in their studies, had created that molecular fast of a 5-day length was so that people, obese people, for example, will at least get 1 day of autophagy. And it seems that exercise is a better tool for stimulating autophagy and all of the other benefits that we're talking about. And so if you're exercising regularly, then, you know, what I customarily say, particularly to women who are in their cycling years, is a 12 to 14-hour fast. It seems optimal, right? It's giving your body time to relax, and you're not constantly working, right? And it can focus on other things. But it's also not that difficult to stick to. And it's what I find children, having had children myself, naturally do. They will naturally eat in their younger years around 5-6 p.m. and they won't think about eating again before 7 in the morning, right? They're naturally doing that. It seems that we're primed for that level of fasting on a daily basis.
Yeah, it certainly seems that way. Another thing to remember is, what specific vector are you trying to get out of fasting? Are you trying to look at more of like the mTOR pathway? Are you looking, you know, there's a lot of different, are you looking at like insulin sensitivity, autophagy in general? And if you're looking at the mTOR pathway more specifically, and a lot of people discuss rapamycin and other mTOR inhibitors, and then people also discuss BCAAs. But you see some people who are intermittent fasting, but that to make their fast last longer, they take a protein like casein protein, which has a huge amount of BCAAs in it, and also it's just a very slow digested protein. So they're activating mTOR, and in theory, it looks like they're fasting, but they're not actually getting that benefit of fasting, because they're having a huge casein protein shake right before their fast.
And this because the BCAAs are kind of spiking insulin potentially, whereas if you're having a full spectrum essential amino acids, that seems, in my experience, to provide less of a bump from what I've seen in terms of the impact on fasting.
Also, just because a lot of the amino acids in the casein protein, including the BCAAs, are activating the mTOR, the mammalian target of rapamycin. So their mTOR is active. They're in more of a anabolic state from that vector. And that's one of the major benefits of fasting. So they can they're negating a lot of benefits from fasting. Ironically, a lot of toddlers and babies do this as well, because if you look at what we give them before their fast, in some cases, is milk protein, which has a lot of casein in it. So again, they're activating mTOR, which is a good thing in children, because you want them to be able to grow overnight, and you want them to have enough IGF-1, which dairy can help with. And you don't want them to be too catabolic.
Yeah, that's true. This is in very young children, right? And what about, so, but if you're having something like that immediately pre-workout, when I was chatting this over with Dr. Stacey Sims, literally just a few days ago, and we were chatting about how actually there's some evidence that by having some amino acids pre-workout is supportive for women, and also protecting against any kind of catabolic effects of breaking down the muscle tissue. And you're getting those benefits of autophagy from the exercise session itself. Yeah,
the ideal scenario for timing of nutrients around exercise is, as long as you're able to tolerate it, is a medium or small pre-workout meal with amino acids, and also a post-workout meal too. So timing your nutrients around the time of exercise, perhaps not as much really vigorous exercise, but for mild to moderate exercise, that nutrient timing certainly will matter. If people want to test this out themselves, they can also do a 24-hour fast and then exercise fasted, and they can do a small pre-workout meal and see which one they feel better at, as long as you're able to tolerate it. But yeah, I agree. Amino acids around the time of workout, there's no such thing as like there's no anabolic window, but it can help for health purposes other than building up lean body mass.
And you were talking earlier actually about optimizing the cortisol rhythm in the morning. So we've got that cortisol awakening response of that sort of first 60 minutes of the day. If I don't exercise first thing, it's probably not going to get done. It definitely won't get done after midday. That's just the way I am. Even though I can see all of the circadian rhythm evidence that I'm stronger in, I've got great aerobic action times. No one's ever won an Olympic medal. Good job. I'm not going for one of those before midday and all this stuff, but it's just not going to happen. And I'm a very just naturally early riser. So for me, 5 a.m., I'm ready. I'm in the gym at 5:30 and I really get a good workout and I love it. Yeah. I'm curious if you're going to tell me. Oh, good. Thank God for that. I thought you might be saying, no, Angela, you're just destroying your hormones and your adrenal health. But it's just nice. And I feel that I am taking, it's just, I was talking to Dave Asprey about it, and he was, I think he was saying, we don't want to raise cortisol too much in the morning. Actually, it doesn't raise cortisol. I don't feel in me. I feel primed and kind of excited and motivated, but calm for post-workout. And I'll either meditate directly before or directly after it anyway. Yeah, I mean, it sounds like you agree with me, but I'm just curious what you think around that and how we optimize that cortisol in the morning.
For most individuals, exercising right when you wake up in the morning, ideally before any kids would wake up or before any distractions start coming in or calls. For me, that is the only time that I can exercise. And the fringe 5% benefit, I'm not a professional athlete or anything, so that doesn't matter to me. What matters to me is getting it done. So just like the best diet is one that you can adhere to, the best exercise protocol is also one that you can adhere to.
I agree.
For most people, that's first thing in the morning.
First thing in the morning. And the cognitive benefits I find are profound. And also, I was speaking to a sleep scientist about this. Actually, it helps to make up, particularly when you're having things like creatine, for any deficits in sleep. So kind of having had a poor night's sleep isn't really the excuse for not getting up and exercising, because actually you're doing your body, I think, so much good by exercising, right?
I agree. And obviously there's law of diminishing returns applies there, like it does to most things, where if you sleep for 2 hours, then you probably don't want to get up and have a really vigorous exercise. But in most cases, that certainly applies.
And then with sleep, you were talking about that as one of your pillars. What are your thoughts there? Because some people, I mean, when I've looked at genetic reports, I see indications that actually this 7 to 9 hours isn't uniform across the population. There are, just like we have early morning risers and we have night owls, there are some people who actually seem to need less sleep than 7 hours. I know when I look at research, if you go sub 6 hours, it seems to actually be putting your health at risk. And there's a very small, just like we're told not to sleep over 9 hours, there seems to be a small section of the population who do actually need sort of 9 hours or more sleep. What have you found there? And because I seem to function very well on 6.5 hours, but I carry APOE4, one copy of it. This is always in the back of my mind. I'm just curious your thoughts in terms of you have that pillar too of sleep.
Those genetic markers certainly run in my family as well.
Oh, do they?
And some individuals get an extremely low amount of sleep. It is interesting to see how well they function and that they truly just sleep a lot less. But, and I'm not a sleep scientist, and I try to learn as much as possible from scientists like Matt Walker and Andrew Huberman. But what it appears is that if you're getting, let's say 5 hours, 6.5, I'm not sure, that seems pretty close to 7 to me. So I wouldn't worry about that too much. But if you're consistently getting 4 or 5, even if you're functioning perfectly well in the short, medium, and even long term on that amount of sleep, you would be concerned for your health in other ways in the long run.
You would be concerned. Oh, as in if you were sleeping, if you're consistently sleeping like 4 or 5 hours.
Correct. My
Yeah.
understanding is if you're sleeping consistently less than 6 hours, regardless if it's really good quality of sleep and regardless of your function, that you would certainly be concerned for long-term health sequelae.
Yeah, that's what I've heard. I interviewed a chrono biologist around this, sleep scientist, and it was quite interesting because one of the things he had observed through his studies, PhD, was if you are undersleeping, what generally will happen is as soon as you put that alarm off, your body will naturally try to make up the sleep. So you'll oversleep by quite considerably. Whereas for people who are sleeping less, sub 7 hours, so 6 to 7 hours, they will then instead, what will happen is you'll see your stats double down on deep sleep, double down on REM sleep. So the amount and the quality, you seem to then sacrifice light sleep, but you won't end up oversleeping. And that's certainly what I've observed. So I don't know, maybe you can see what happens with that. Don't set any alarms and see what your body does. It's quite interesting. Before you go, you've been so generous with your time. One question that we hadn't hit, and I know I've had quite a few questions around this, is, and I know that it's an area that's growing in terms of research, primary ovarian insufficiency. There's lots of women, sometimes this is happening and it is really insufficiency. It's kind of in their late 30s. There are also women that are just trying to fall pregnant within their 40s more and more now due to the changing lifestyle and environment. What have you found, things that can move the needle on this, on primary ovarian insufficiency, but also on fertility?
We talked about ovarian insufficiency and the potential reversal of menopause in mice earlier, and how things like NAD plus and ATP optimization from those angles can potentially affect it. So for some women, that mitochondrial angle, to have optimal mitochondrial health in the ovary, is a good vector to look at. You can also look at the time of menarche. So when you basically went through adolescence, first period, etc. And if it was particularly early, then perhaps you have excess signaling of things like leptin and gonadotropins. So that's another angle that you can look for to delay the potential time of menopause. And then you can also look at the angle of hormesis and sirtuins, which we also looked at. There's some studies, we mentioned the studies on NMN and NAD+. There's also been studies on a medication known as rapamycin, which of course targets that mTOR that we also looked at. So things like intermittent fasting potentially could help with that hormetic state as well. So there's a lot of different little things, but there's not any one single magical thing. The difficult part of this is up to now, if you have POI, there is no known way to reverse it, which is why a lot of individuals, including myself, are, if you're looking to delay fertility, yes, you can consider those vectors, and there's natural and medications that you can consider that will slow the aging of the ovary, but nothing that we know at this point to reverse it. So for that reason, most clinicians, if you're looking to have fertility into older and older ages, I'm a fan of freezing eggs. So that being said, the technology and the studies are very frequent, and it is an area that we will watch closely.
Interesting. Thank you for that. Very, very helpful. Amazing. Well, thank you so much for sharing so much. I know that you're very active on Instagram. Your knowledge is just incredible. Where can people find you and connect with you?
My main hub is on Instagram. It's Kyle Gillet, MD. And I also have a health optimization clinic that does televisits and in-person visits both. And that is called Gillett Health, and we're on all platforms. I also do podcasts with one of my partners from time to time, and we get far down the rabbit holes of various niches. And his name is James, and the podcast we do is called the Gillett Health Podcast on Spotify and YouTube and such.
Amazing. Thank you so much. We will link to that in the show notes, and everything else you've been talking about, the studies, etc. It's been amazing. Thanks so much for sharing your time.
My pleasure. Thank you.